Hello, and thank you for asking me to participate in this 8th year in review for breast cancer. It's really exciting to participate in your meeting, and I'm sorry I can't be there in person, but I hope very much to see you in 2024 in person. My topic today is HER2-low breast cancer, and we're going to focus on understanding HER2-low, the state of the art. So we know that expression of HER2 is continuous, and we've known that for a long time. The tests for HER2 positive disease have focused on identifying patients whose tumor is HER2 3+ by immunohistochemistry, or in cases of 2+ who have evidence of HER2 gene amplification by in situ hybridization. We know that there's been great discordance between pathologists, even in reading HER2 3+, but in particular in HER2 2+. Now we're faced with trying to understand how good we are at looking at HER2 1+ and 2+, so-called HER2 low versus HER2 0. And that's what we'll focus on today, using the results of DESTINY-Breast04 and then the additional data presented at San Antonio and published this year. So this is the HER2 current testing recommendations based on the ASCO CAP guidelines. Here, as you know, for IHC 3+, greater than 10% of the tumor cells have to have circumferential membrane staining that's complete and intense. Those patients have HER2 positive disease and can access HER2 targeted therapies with great therapeutic benefit. For IHC 2+, the staining is weak or moderately complete, and in 1+, the staining is incomplete and faint or barely perceptible. It's important to keep in mind that the breakpoint is greater than 10% here. And for IHC 0, it's not really 0. It's less than or equal to 10% that's incomplete and faint or barely perceptible. For patients who are 2+, of course, we go on to do in situ hybridization testing to understand whether or not these patients truly will respond to HER2 targeted therapy. If they have gene amplification, and there are a number of different definitions we won't go into, those patients can be treated as having HER2 positive disease. In this publication from Aleix Prat and colleagues from JAMA 2022, they refer to it as ERB-B2 positive because that's the name of the gene. We'll refer to this as HER2 for the purpose of this discussion. So what do we know about HER2 low? Well, we know that HER2 low is much more common in hormone receptor positive disease than triple negative disease. In this important publication from 2021 by Shattini et al., and then summarized in the Pratt paper in 2022, which was really a review paper, it was 65% versus 37%. And here you can see this outline from the Pratt paper looking at ERB-B2 in the very light blue, the gray blue being HER2 low, and then HER2 positive. There's more HER2 positive disease relatively in the hormone receptor negative population in current day testing, which hadn't been seen in the initial days of HER2 positive treatment, where we saw it about 50-50. In this population, you can see that in this dark blue color, teal color, there are quite a number of more HER2 positive tumors using our new definition in patients of hormone receptor negative disease. But the difference in HER2 low is double, as you can see here. And here's the membrane staining for HER2 low. You can see why the confusion exists, because it's so difficult for pathologists to differentiate the 10% and how much the membrane staining is for each tumor cell. Here you have a very clear-cut HER2 negative, which is HER2 0, which is not seen in clinical practice. Additional studies have looked at this relationship in luminal intrinsic subtypes. And again, it's uncommon to see HER2 low in basal-like intrinsic subtypes. It's much more common in luminal B and even luminal A. So we've also seen that ERB-B2 transcript abundance varies by receptor subtype and HER2 low versus HER2 0. Again, here you can see that patients who have triple negative breast cancer have a relatively lower ERB-B2 relative transcript abundance versus patients hormone receptor positive. And then HER2 low has a higher, and this is shown here, ERB-B2 transcript abundance versus HER2 0. And that's at least comforting that we know a little bit of what we're talking about in comparing transcript abundance to immunohistochemistry. We know that HER2 low biology is really driven by hormone receptor status. So when we talk a little bit later about the prognostic implications, it's important to keep in mind that most of these prognostic studies, pretty much all of them, didn't really take into account the intrinsic subtypes, which I think trump anything that HER2 low could give us in terms of prognosis. So let's talk about T-DXd and why this is important to us now clinically. So T-DXd, as you know, is a second generation antibody drug conjugate with a high drug to antibody ratio of 8:1, a cleavable linker, and a highly potent topoisomerase 1 inhibitor payload called deruxtecan. The cleavable linker, as well as the membrane permeability of the payload, the deruxtecan, results in a bystander effect shown here in this cartoon, which I think is the nicest cartoon that we have for this. In a phase 1b study, we saw in patients who had HER2 low metastatic breast cancer defined as IHC 1+ or 2+ without evidence of gene amplification by ISH, a median progression-free survival of 11 months and a response of 37%, really quite dramatic in these 54 patients. And that led to the phase 3 Destiny Breast 04 trial, which has been so practice changing. So in this trial, patients who had HER2 low disease that was defined centrally, so you had to send the tumor in centrally, who'd received 1 to 2 lines of prior chemotherapy in the metastatic setting, so they couldn't have received more than 2 lines, and at least 1 line of endocrine therapy, were randomized 2-to-1 to receive T-DXd every 3 weeks versus treatment of physician choice, including the chemotherapy agents outlined on this slide. It's important to keep in mind that CDK4/6 inhibitor treatment was not required in this study, although about 70% of patients received prior CDK4/6 inhibitors. The primary endpoint was progression-free survival by blinded independent central review, but only in the hormone receptor positive population. They had a key secondary endpoint looking at PFS in all patients, and then the look at triple negative patients was an exploratory subset analysis. Here you can see relatively equal percent of patients were 1+ or 2+-ish negative. The median number of prior chemotherapy lines in the metastatic setting was 1. So most of these patients were treated in the second line setting. Almost no patients received 3 lines, which would have made them ineligible. So that's a good thing. The median number of endocrine therapies was 2. And I mentioned that about 70% of patients received CDK4/6 inhibitors. As you know, median progression-free survival was dramatically improved in patients receiving T-DXd versus chemotherapy of physician choice, where about 50% of the patients received eribulin. The hazard ratio was 0.5, almost a doubling of PFS, going from 5.4 to 10.1 months with a delta of 4.7 months. And then looking at the all patients in the secondary analysis, you can see that this is maintained. And that makes perfect sense because only a tiny number of patients, 58 patients out of this large trial, had triple negative disease. So you wouldn't have expected those patients to adversely affect the outcome. The hazard ratio is still 0.5. And here this is summarized at the bottom of the slide based on the presentation at ASCO and the publication in the New England Journal. Looking at efficacy in additional endpoint included overall survival. And this was interestingly a secondary endpoint, but at the first analysis shown here, there was a marked significant improvement in overall survival in patients receiving T-DXd versus TPC with a delta of 6.4 months and a hazard ratio of 0.64. And I think it's really quite remarkable looking at these different landmark analyses out to 24 months where there's still a big difference here. And the median was 17.5 to almost 24 months. So 2 years versus less than 2 years. So really a big difference clinically for our patients. The same difference was seen in all patients when you add in those 58 patients who had triple negative disease. And then overall response was markedly improved, going from 16 to 53%. And then here I'm showing you the first data from the unplanned subset analysis in triple negative disease that was HER2 low centrally defined. The response was 17% and 50%. No difference in complete responses. Really interesting here. The main differences in all populations was primarily in partial response and then clinical benefit rate, which was more than double for HR positive disease as well as for triple negative disease. And as you would expect, median duration of response was longer. So what about if we look at the subset analysis in hormone receptor negative disease? Remember, this is not powered in any way for a definite response in triple negative breast cancer. And it's important to keep in mind as we go through the prognostic implications that patients who have triple negative disease that's HER2 low are less likely to have basal disease. They have more chemotherapy responsive disease, which is an important difference. This is not all comers for triple negative breast cancer by any means. So in hormone receptor negative disease, there were 40 patients treated with T-DXd, but just 18 with treatment of physician choice. And the PFS went from 3 to 8.5 months with a hazard ratio of 0.46, a delta of 5.6 months. And for overall survival, that delta was almost 10 months, going from 8.3 to 18 months. And I think that it's important to keep in mind that when you see these differences between PFS and OS, it is likely that there's something to do with the patient population in these very small numbers, hazard ratio 0.48, but still quite encouraging and led to overall approval by the FDA of T-DXd in the HER2 low population without differentiating out the patients who had triple negative disease. In terms of toxicity, the most common toxicity we know well from the HER2 positive situation was nausea, and neutropenia is quite uncommon, much more common in patients who have received TPC. And I have to say that I can count on one hand the patients who had neutropenia with T-DXd. Mostly they're very heavily pretreated patients. Fatigue is also an issue. Alopecia was seen in 38%, smaller percentage having complete alopecia, but it's unpredictable. But this nausea that is prolonged after the initial infusion, that can really peak at day 7 to 10 or continue for that time is important. And we've used the drug olanzapine with very good effect in these patients. They take a small dose, 2.5 milligrams at bedtime, even a half a pill if they're sleepy, and it really helps that really delayed and late nausea, which can impact quality of life. The most common reason to discontinue treatment for T-DXd was ILD pneumonitis, and we'll talk about that in just a moment. So the most important adverse events of special interest were left ventricular dysfunction, which really wasn't a big issue, which is nice because these patients have not received prior HER2 positive disease, HER2 targeted disease. So we didn't really know how their hearts would manage. There was just one patient that had a grade 3 drop in ejection fraction and recovered after treatment. For ILD, however, 12% of patients had a drug-related interstitial lung disease adjudicated by a central committee. And you can see that 3 patients died, 0.8%. And it is actually an incredibly important area to provide further education and understanding about both identifying and treating ILD so that we have no mortality from ILD as seen in the HER2 positive phase 3 trial DESTINY-Breast03. So the recommendations for ILD here are important, and I think that we also have changed our screening a bit based on understanding of time to first ILD event, which is largely in the first year. I will say, however, there have been fatal events that have been seen at about 20 months, and even one that occurred at about 40 months into treatment. So the risk is not gone, it just drops off. So for patients who have evidence of ground glass opacities on scan, we hold the drug, give steroids, and wait for recovery. We usually rescan in 3 weeks, and then we restart if there's significant improvement. For patients who have symptomatic ILD, the recommendation is to permanently discontinue, and we'll see what happens over time as we treat patients and whether or not, for example, if you're not sure with a mild cough, a patient who also had a viral infection or asthma, I've restarted successfully if I wasn't convinced that this was ILD and the CT scan has cleared, but this is really important. At San Antonio this year, in one of the poster discussion sessions, Shanu Modi presented subset analysis from DB04, and as you would expect, based on almost any characteristic, all of these hazard ratios line up to the left of 1. So that includes CNS metastases, although they had to be controlled, prior anthracyclines, disease burden, rapid progression, etc., CDK4/6 inhibitor use, and age. They also looked at overall response, and overall response was similar regardless of these adverse prognostic factors. And then safety didn't really vary based on prior CDK4/6 inhibitor or disease burden. So very helpful to see. So what about HER2 low expression? What do we understand about this? Let's use some of the published data as well as the data from a fascinating session on HER2 low with multiple posters trying to investigate this in large populations. and clinical trials to better understand HER2 low. So this is a very nice publication by Paolo Tarantino, who's been a long-term fellow at Dana-Farber, looking at this. And we've seen this, actually, there was data from San Antonio that I don't have time to show you that showed that this is true. When you go from the early stage to metastatic setting, you see a change, but also in the neoadjuvant setting, in the poster by Denkert et al., if you looked at HER2 low at diagnosis from the biopsy and then at the surgery time, you also see a shift in HER2 low status. So this is dynamic. This is not, PIK3CA or HER2, where we really see this conserved over time. So that makes us worry about the benefits of looking at this as a prognostic factor, although clearly it's predictive for T-DXd benefit. So here you can see patients have HER2 0 in the primary status tumor or HER2 low, that they can change from low to 0, a smaller number, but from 0 to low. And then you can see that there's a big change that's more marked going from HER2 low to 0 in triple negative disease, and a little less marked from HER2 low to 0 in ER positive disease. And then absolutely no prognostic impact on overall survival, PFS, or disease-free survival. This is a fascinating study published by David Rim's group, by Fernandez in JAMA this year, that looked at the distribution of IHC scores in 170 cases. These were blinded cases from thousands of patients. They selected 18 pathologists, read these whole tissue sections. And what they found was that there was only 26% concordance between 0 and 1+ between these very expert pathologists, and 58% concordance between 2+ and 3+. And that's really seen here in terms of the percent of the readers who were agreeing with each other in terms of it being 0 in the blue here versus the yellow 1+, 2+, or 3+. And you can see the concordance here between 0 and 1+, 2+, versus those who are looking at 3+ is really, here the concordance is very good, here the concordance is terrible. So it does suggest that we need a new way of trying to classify and understand low expression of HER2. So what did we learn about pathology and scoring at San Antonio? So Aleix Prat looked at the Destiny Breast 04 data in terms of agreement between the historical, so what you found at your site, versus the centrally confirmed HER2 low status, using the Pathway 4B5 IHC assay and the Ventana Inform HER2 dual-ish assay. Viali in Italy looked at rescored and historical HER2 scores and found an agreement of 81.2%. So these all are about 80%, numerically greater for HER2 low than IHC 0. And then Rushoff looked at patient population similar to the Fernandez population, but found a greater than 80% overall rater agreement when you trained everybody ahead of time and made sure that people generally agreed. And so they thought that in these 80 pathologists that you could get an acceptable level of accuracy, which David Rim doesn't believe, but I think that's because he has another biologic test to look at HER2, so he's a little bit biased in that way. But I think it's quite intriguing that there may be several ways to get concordance. So this shows you the data from Pratt looking at the samples that were in DB04 from this poster and trying to look at which ones were IHC 0 by historic result and central testing. But you can see some of these IHC 0, one case was actually HER2 positive, which is the most scary part because you don't want to miss HER2 positivity. But overall, 78% of patients that were HER2 low by local testing were HER2 low centrally. And in the 22% discordant samples, 88% were 0 and 12% were 2+-ish positive or 3+. And so overall, 29 patients out of those patients who were thought to be low actually had HER2 positive disease. So we have to be very careful about this for our patients. It didn't matter whether or not the samples were primary or metastases, and it didn't matter how long it was from tissue collection until study entry. So these data have led us clinically to say, oh, if somebody was HER2 low locally in early stage, and now they're HER2 0 in the metastatic setting, we can still try T-DXd. So that's actually the implications at the moment, and we'll see how that really plays out in real world analyses. Now, what about the prognostic impact of HER2 low and early stage disease? There were two large series before San Antonio, the D-DXd study, looking at the German breast group, 2,300 patients, and they said that there was no difference in PCR based on HER2 low versus 0. Most of the patients had hormone receptor positive disease, but in the triple negative population that represented only 36%, they seemed to have a worse outcome if they were HER2 0 versus HER2 low. And I think that's just the intrinsic subtype. They were more basal-like and had resistant disease, and that HER2 low just comes along for the ride, but doesn't have independent prognostic significance. Tarantino published actually presented at ESMO Breast Cancer, a much larger data set of over 5,200 patients, 55% were HER2 low. And of course, the rate of HER2 low increased with increasing ER expression. And after you corrected for hormone receptor expression, there was no difference in PCR rates and no difference in outcome, as I showed you earlier from his paper. And this is in a larger subgroup. So this, I think, is really the definitive answer, despite all the data we saw at San Antonio. And these are all the different studies looking at the different number of patients. So this is a huge amount of data. Of course, I can't go through it all individually, but I've summarized this for you. And these slides can be available to anybody who wants them, just in terms of seeing these summaries. So basically about a little under 9,000 patients where it was thought to be a separate entity. In the PALACE trial, it was interesting. The biopsy, but not the surgery sample, was linked to improved invasive disease-free survival in HER2 low. But again, I think this might be a difference in intrinsic subtyping, and HER2 low is just a correlate, really, and not an independent factor. And I think that of those, that's probably the most. There were several studies that suggested and have shown now that HER2 low has distinct molecular subtypes, which is exactly why people have confused this into prognosis, basically showing that if you have HER2 low, you're more likely to be luminal than basal-like. And there are other factors that are part of the molecular subtypes. You have better prognosis disease, essentially, because of these molecular factors, not simply because you have HER2 low. So that's basically what we've seen from those. And then there were patients who had first-line CDK4/6 inhibitors plus endocrine therapy in an Italian study where they also saw they had a HER2 low status had negative prognostic value in the hormone receptor positive group. But again, I think that this is a difficult, because you have to keep in mind that if people are wrong a substantial number of times, as David Rim suggests, in determining HER2, the difference between 1+ and 2+ and 0, that basically you're having that huge factor that causes bias in your analyses. Now, there's also not a separate entity. This is a huge study population, over 17,000 patients. Laura Spring looked at R-Exponder and the trial that looked at the recurrence score in patients up to 25, hormone receptor positive, 1 to 3 positive nodes. HER2 low had no impact on IDFS versus HER2 0. Very compelling data in this huge number of patients. Bansal looked at over 11,000 patients, shared genomic features with hormone receptor positive and HER2 negative diseases. I've been noting as well, no difference. And Mara looked at the pathology and said it really wasn't a distinct pathologic subtype. There are differences in genomics. And then Tarantino, again, had a Dana-Farber study over 7 years of 1,000 patients, and the genomic landscape didn't really differ. If you looked at patients who had triple negative versus HR positive disease and balanced it based on that factor, there was higher ERBB2 allele in HER2 low, as I showed you earlier. So this is actually data from Viali that also looked at no differences in patient demographic or clinical characteristics in HER2 low versus HER2 0. I think very interesting. And this population of patients that they analyzed in 789 patients. Again, no difference in time to subsequent treatment in these patients, hormone receptor positive, hormone receptor negative based on HER2 low versus IHC 0, and no difference in overall survival. And then this data from Pfeiffer et al. Looked at survival outcomes in the National Cancer Database in the US over 9 years. Again, 1 million patients, but HER2 low wasn't even defined as a specific subtype then. So we have to be quite careful. A little bit of difference, but not much. And overall, these patients, as you can see, there's no prognostic value in HER2 low versus HER2 zero. And then Laura, this is Laura Spring's data in RX Responder I thought you would be interested in. If you look at chemotherapy versus endocrine therapy, you see the differences in RX Responder by menopausal status, and there's no impact from HER2 low versus HER2 zero. Data from the New England Journal paper, which looks at, sorry for that noise, data from the New England Journal paper looks at differences in overall response versus progression-free and progression-free survival based on HER2 IHC levels from DESTINY-Breast04. And you can see here that the IHC1 is in dark blue, IHC2 is in light blue, absolutely no difference. I mean, this is totally unremarkable. It does bring up the question about whether or not we're even defining IHC low appropriately, because it doesn't seem to make any difference if you have a little bit more or a little bit less here. Here is disease progression and, of course, response. So then the question is whether or not the tumors that we classify as IHC 0 might benefit from T-DXd if they have a little bit of staining. Remember, that's, this 10% guideline. So maybe if you have just a little versus 0, that you would still respond. Data actually from the DAISY trial, if you look at this slide, there was actually good responses in patients who were IHC 0, HER2 non-detected by ASCO-CAP guidelines, but progression-free survival was actually quite short in the triple-negative population. This is hidden here, but progression-free survival was just 2 months in the triple-negative population and about 4 months in patients with hormone receptor-positive disease. So it brings up an intriguing question that will be answered in DESTINY-Breast06. This is a large trial with over 800 patients who will be randomized, 850 patients, to receive T-DXd or investigator choice chemotherapy as first-line treatment for hormone receptor-positive HER2 low or HER2 zero qualified as ultra low metastatic breast cancer. So patients have to have received prior endocrine therapy. They don't have to have received a prior CDK4/6 inhibitor, although they require a specific percentage to be enrolled who've received this targeted agent. Patients are chemotherapy naive, and a subgroup of patients will be included. It's not the primary endpoint, as you can see here, but a subgroup of patients will be included of ultra low disease. So they don't have 0, but it's less than 10%. So this will be very, very interesting data, and this trial is rapidly accruing. So based on the data from DESTINY-Breast04 on August 5th, the US FDA approved T-DXd for patients who have metastatic HER2 low breast cancer who've received at least 1 line of prior chemotherapy in the metastatic setting or who've developed recurrence within 6 months of completing adjuvant chemotherapy. Of course, sacituzumab is also approved as is also listed in the NCCN guidelines. It's only approved for triple negative disease, but we hope to hear about hormone receptor positive later line therapy from the FDA in February of this year. Now, I was also asked to briefly cover the HER3 ADC, patritumab deruxtecan. This data resulted in this trial has resulted in interest in studying this HER3 ADC in patients with hormone receptor positive disease, and I believe that a neoadjuvant trial is in the works in hormone receptor positive HER2 negative disease. They looked in this study at hormone receptor positive HER2 negative, a smaller group of triple negative, and a tiny group of HER2 positive. In the hormone receptor positive, they included HER3 high and low, in triple negative HER3 high, and in HER2 positive HER3 high. Now, the HER3 was defined by an antibody that's been used, but hasn't really been validated or vetted in any large population because we don't look at HER3 clinically other than this. The ADC uses the same toxin, deruxtecan, and an antibody to HER3, and there is evidence of a bystander effect. So the dose expansion in triple negative disease is 1 to 2 prior chemotherapy regimens. In the dose finding and expansion, 2 or more chemotherapy regimens. The overall response, as you can see here, was 30% and was independent of membrane HER3 expression, interestingly, and membrane HER3 expression went down with treatment, interestingly, as you might expect. The response in HER3 high triple negative disease was an impressive 23% and 43% for HER2 positive disease. Progression-free survival also quite impressive in these reasonably heavily pretreated patients in the initial group, as was overall survival. So there's a lot of interest in this. It's a fascinating agent because it causes a toxicity we haven't seen before, which is thrombocytopenia, and a little more than a quarter of patients had grade 3 thrombocytopenia. There was ILD in 6.6% with 1 death. So we'll wait to see what happens with this agent. So I'll leave you with a roadmap for metastatic breast cancer where we're still using endocrine therapy and targeted agents first. This is chemotherapy. In HER2 low patients, T-DXd is the treatment of choice in the second line and may move in the near future to the first line setting. We do need, however, to better define HER2 low testing. Further definition of HER2 low is important. I don't think it has any prognostic impact. The IHC assay is not very reproducible between all of our pathologists around the world, and new directions to more accurately define HER2 protein expression are under development. There are many ongoing trials. I showed you the first-line trial in metastatic hormone receptor positive disease, but there are trials going on in the neoadjuvant setting as well as the post-neoadjuvant setting planned, and new antibody drug conjugates such as the TROP2 ADC datopotamab deruxtecan are also being studied in this area. Toxicity management in these patients is absolutely critical. We have to get scans because we don't know when patients have grade 1 ILD. Identification is critical to avoid progression to symptomatic ILD as well as death from ILD. With that, I'll conclude and thank you very much for your attention.